This lecture, entitled Palliative Care for the Psycho-Oncologist, is one webcast of the multilingual core curriculum prepared and presented by the International Psycho-Oncology Society with the generous support of the European School of Oncology. These webcasts are provided for the education of oncologists and other physicians and healthcare professionals involved in cancer care. These webcasts are provided on both the EPOS and the ESO websites. This lecture was written and presented by Dr. William Breitbart MD. Professor Breitbart is Chief of the Psychiatry Service and attending psychiatrist of the Pain and Palliative Care Service, Memorial Sloan Kettering Cancer Center, New York, USA. Dr. Breitbart is Professor of Psychiatry at the Weill Medical College of Cornell University. He is a founding member of the International Psycho-Oncology Society and has been a member of the Board of Directors of IPOS for 10 years. He is currently Vice President. Dr. Breitbart is also Editor-in-Chief of Palliative and Supportive Care, an international palliative care journal published by Cambridge University Press. Dr. Breitbart helped found IPOS Press, which will soon be publishing the Pocket Handbook of Palliative Care for the Psycho-Oncologist. One of the most challenging roles of the psycho-oncologist is to help guide terminally ill patients through the physical, psychological, and spiritual aspects of the dying process. Patients with cancer, AIDS, and other life-threatening illnesses are at increased risk for the development of major psychiatric complications and have an enormous burden of both physical and psychological symptoms. In fact, surveys suggest that psychological symptoms such as depression, anxiety, and hopelessness are as frequent, if not more so, than pain and other physical symptoms. Concepts of adequate palliative care must be expanded beyond the current focus on pain and physical symptom control to include the psychiatric, psychosocial, existential, and spiritual aspects of care. The psycho-oncologist, as a consultant to or member of a palliative care team, has a unique role and opportunity to fulfill this promise of competent and compassionate palliative care for those with life-threatening illness. This IPOS online core curriculum guides the psycho-oncologist through important aspects of care of patients with advanced illness. We review basic concepts and definitions of palliative care and the experience of dying, including a global perspective on death and palliative care. The role of the psycho-oncologist in palliative care is reviewed, including psychotherapeutic approaches and issues such as bereavement, spirituality, cultural sensitivity, communication, and psychiatric contributions to common physical symptom control. Cancer is a leading cause of death worldwide. Over 10 million new cases of cancer occur annually, approximately 5 million cases in developed countries and 5.5 million cases in less developed countries. From a total of 58 million deaths worldwide in 2005, 7.6 million deaths, or 13%, were caused by cancer. 76% of these deaths are in developing countries. Of the 8 most common forms of cancer, 5 are more prevalent in developed. In 2005, more than 70% of all cancer deaths occurred in low and middle income countries, where less than 10% of resources committed to cancer control are spent. Cancer prevalence differs in various countries. Oral cancer is more common in India. Stomach cancer is more common in Asia, Latin America, and Eastern Europe. Cervical cancer more common in India, Africa, Latin America, especially among lower socioeconomic classes. Lung cancer more common in North America and Europe, and liver cancer more common in Africa, East Asia, and the Western Pacific. Lung cancer is the most frequent cancer worldwide. This is a result of tobacco use, which is rapidly increasing in the developing world. 90% of lung cancers are incurable, and all of these patients are in need of. When one looks at cancer control priorities and strategies by cancer site, it becomes clear that treatment is curative in only 3 of the most common cancer types: breast, cervix, and oropharyngeal cancers. Palliative care, however, is needed in all of the 8 most common forms of cancer. There's been an increase in cancer incidence due to the fact that deaths from cardiovascular disease are declining. Many individuals are surviving to older ages when cancer is more likely to occur. There has been a steady increase in tobacco use, and changes in diet, decreasing physical activity, and increasing obesity have also been environmental and behavioral contributors to the increase in cancer incidence worldwide. Jan Stensvart, who headed the WHO Palliative Care program, said that we're all born to die. In 1997, 50 million people died. He said we should give those who are to leave life the same care and attention we give those who enter life. Deaths from cancer are projected to continue rising. By 2015, it's estimated that 9 million deaths will occur related to cancer, with 2/3 of them occurring in developing countries. By 2030, approximately 12 million deaths will occur. 67% of men and 60% of female cancer patients die of their disease, higher rates of death occurring in developing countries. 1/5 of all deaths occur in the developed countries, and 1 out of 10 of all deaths occur in developing countries, with rising incidence. In the United States, the 3 leading causes of death are heart disease, cancer, and stroke. Causes of death often differ by race and age. For instance, amongst African Americans in the United States, heart disease and cancer are number 1 and 2 cause of death, and homicide has replaced stroke as the 3rd most common death. Some interesting statistics related to patients' health prior to death. If one looks at patients in the United States who died, 53% of those had good or excellent health at 1 year prior to death. 24% reported good or excellent health at 1 month prior to death, and 11% of patients had good or excellent health the day before death. This raises the question of the difficulty of prognostication when it comes to death and related to a variety of causes. On the last day of life, in a population of patients with cancer, 75% of those patients who died the following day, 75% were non-ambulatory. 40% had difficulty recognizing family members, but 60% obviously were able to recognize families, and 25% were able to walk around and be ambulatory. 55% were unable to eat. 44% were short of breath. 33% reported pain. What's clear from these statistics are that a significant number of patients are ambulatory, coherent, able to eat, and with relatively little in the way of physical symptoms such as shortness of breath and pain on the day. One of the difficulties in allowing physicians and other clinicians to accurately prognosticate death is the fact that there are a number of different death trajectories that can occur. This is an example of a death trajectory for a sudden death from an unexpected course, where an individual is in a good state of health until some sudden unexpected cause, stroke, heart attack, trauma. This next death trajectory is a prototypical death trajectory for progressive disease with a terminal phase such as cancer illness. Individuals are in a reasonably good state of health, and then they're diagnosed with an illness such as cancer. They then proceed along a trajectory of steady decline, leading to another typical death trajectory involves a trajectory of death for an advanced illness that's marked by slow declines with periodic crises and then sudden death. This is also not an atypical death trajectory followed for many patients with cancer or illnesses such as HIV disease, where one has a relatively stable level of health, and then particular acute illnesses or crises occur, and then followed by a slow decline, and then eventual death during one of the acute crises events, such as infection. The WHO has defined palliative care, as have a number of other organizations. The World Health Organization defines palliative care as the active and total care of patients whose disease is not responsive to curative treatment. Many aspects of palliative care are applicable early in a disease such as cancer and HIV disease, and is not limited to the last weeks or months of life. And many of these aspects of palliative care can take place or be provided in conjunction with anti-cancer treatment. Palliative care focuses on symptom control as well as psychological, social, and spiritual. The Canadian Palliative Care Association defined palliative care in this way. Palliative care as a philosophy of care is a combination of active and compassionate therapies. It's intended to comfort and support individuals and families who are living with a life-threatening illness. Palliative care strives to meet physical, psychological, social, and spiritual expectations and needs while remaining sensitive to personal, cultural, and religious values, beliefs, and practices. Palliative care may be combined with therapies aimed at reducing or curing the illness, or maybe the total focus. If one looks at this schema, past concepts or models of palliative care really dichotomized care into active anti-cancer treatment or palliative care, which occurred in the last days, weeks, or months of life when no curative treatments were possible. So that patients would be receiving anti-cancer treatment from the time of diagnosis until a point was reached where there was no potential for prolongation of life or cure, at which point then there was a transition, a rather abrupt transition, to palliative care, supportive care, and symptom control, such as pain relief, then followed by death. This past model of cure versus care has been replaced by the current model of palliative care, which described in this schematic drawing suggests that palliative care is provided along with active aggressive care from the very moment of diagnosis. The proportion of palliative care and supportive care changes as disease progresses, and as more and more active, curative, or life-prolonging treatments become less available. As active treatments start to diminish, palliative treatments that have palliative intent become more part of the picture and become more intense, leading up to death. And then what's also important in terms of this current model of palliative care is that provision of care does not end with the death of the patient, and the unit of concern is the patient and the family. And so the bereavement processes of the family are an important focus of palliative care as well. And those are provided by the palliative care team. So this current model of palliative care is a drastic change, a philosophical change from past models of palliative care, in which palliative care was merely provided in the last weeks or months of life and did not continue after death. The World Health Organization has suggested that practitioners of palliative care, including psycho-oncologists who are involved in palliative care teams, need a variety of skills. These skills include communication skills, skills in aiding patients to make decisions, management of complications of treatment and complications of disease progression, symptom control, including both physical as well as psychological symptom control, psychological and spiritual care of the patient, family, care of the dying. The WHO states that any national cancer control program needs to address palliative care. The WHO has also suggested that palliative care requires several components in terms of a model of organization of palliative care services. Fully developed palliative care programs now generally include a home care program, providing palliative care in the home, hospital-based consultation services providing palliative care consultation to patients who are hospitalized, an ambulatory care program or a daycare program providing physical and psychological symptom control, an inpatient care program, usually a number of inpatient palliative care beds on an inpatient unit whose size really depends on the community that's being served, to help care for patients whose palliative care needs are more acute and complex, a bereavement program to provide counseling for family members and a community, training programs, usually involving fellowship training programs in advanced specialty of palliative care, and research programs in palliative care. And many palliative care programs now, in addition to having this variety of clinical care and training and research programs, also have internet-based services. One example of that is the Canadian Virtual Hospital. There's been a great deal of progress made in hospice and palliative care over the last decade or two. 80 countries have hospice and palliative care services established or planned. Over 5,000 established or planned hospices or palliative care programs around the country. Less than 1% are AIDS-focused. Most are cancer-focused. Very few countries have a spectrum of models of care that range from inpatient units in hospital consultation teams, ambulatory care, or palliative care clinics, etc. And what's been clear from the literature is that palliative care has only been established successfully where specific physicians have chosen to work full-time in this. This slide shows the estimated number of hospices and palliative care services around the world. In the Americas, there are about 4,000 hospices and palliative care programs in the United States. Canada has about 600. In Europe and the UK, over 1,150 programs, and in Australia, 230 programs, 102 in Japan. So hospice and palliative care programs are available in almost every region of the world. Certainly certain countries have much more in the way of hospice and palliative care programs, particularly Canada and the United States, much of Europe, and Australia and Japan. There have been There are a number of national and multinational palliative care associations that have developed over the last decade, including the European Association of Palliative Care, the Multinational Association of Supportive Care and Cancer, the International Association of Hospice and Palliative Care. There is a large number now of palliative care journals, approximately 12 or more journals focusing on palliative care, 6 in the last 4 years. Most are international. The journal Palliative and Supportive Care, published by Cambridge University Press and affiliated with IPOS, is the only palliative care journal which focuses on the psychiatric, psychosocial, and existential aspects of palliative care. And academic departments of palliative medicine have been developing in the United States. In particular, 6 new departments in the United States. There are several departments and chairs of palliative care in Canada, the UK, and Australia. Fellowship training and specialty certification in pain and palliative medicine has been growing in the United States. There are 28 pain and palliative medicine fellowship training programs that have developed for a newly established subspecialty of palliative medicine. There are a variety of initiatives in funding research and delivery of palliative care services from a variety of philanthropic organizations and institutes of health from in a variety of nations and countries. There have been a number of initiatives in healthcare funding reform that have been focusing on finding ways to more adequately pay for palliative care. This is a bigger problem in the United States than in other countries that have government-provided health care for all of their citizens. Some of these initiatives have included in the United States initiatives in symptom control research from our National Cancer Institute, the American Medical Association establishing a program of end-of-life care training, palliative care guidelines from the National Cancer Center networks, and several Institute of Medicine reports that have been focusing on improving palliative care for cancer. There have been a number of barriers to adequate end-of-life care that have been identified by the National Cancer Policy Board in the United States. They point out a number of deficiencies and barriers. One of them is the separation of palliative and hospice care programs from cancer treatment programs. Only in the last 5 to 10 years have palliative care programs been established within cancer centers, for instance, in the United States. There's inadequate training of healthcare professionals in palliative care. There are inadequate standards of care and disparities of care, particularly in the United States. There's lack of information for the public on palliative care, and there's low level of public sector investment in palliative care research. In developing countries, no efficient palliative care is offered to 8 out of 10 cancer patients who are incurable at the time of diagnosis. Part of the reasons for that are unequal access to care, insufficient funding and lack of national policies on palliative care, poor availability of opioid analgesics. Pain is the most common symptom which cannot be adequately controlled without access to opioid drugs. 70% of global consumption of morphine occurs in Australia, Canada, France, UK, and the United States. Average daily consumption of doses of morphine per million inhabitants is a rough measure of adequacy of pain control in palliative care settings. And as you can see from this particular slide, countries like Sweden, Canada, the United Kingdom, the United States, Switzerland, Netherlands, Israel, France, and Japan tend to have high levels of daily consumption of doses of morphine per million inhabitants. But as one starts to leave these developed countries and move into more developing countries such as Brazil, South America, and Africa, the daily consumption of opioids is dramatically lower and quite inadequate. So this is a rough measure of the adequacy of pain management in these countries. There's been another identified barrier to palliative care delivery is inadequate training of healthcare professionals. There's also been misperceptions about palliative care. One of the misperceptions about palliative care is that palliative care perhaps hastens death. One of the observations has been that many patients die shortly after being transferred to hospice care, for instance. In the United States, on average, patients die 3 days after being transferred to hospice care. In a very large 2007 study by the National Hospice and Palliative Care Organization looking at survival rates in about 5,000 cancer patients transferred to hospice and others who have not been transferred to hospice but receive palliative care in hospital settings or home settings. Hospice patients receiving palliative care treatment survived an average of 29 days longer than patients who did not receive hospice care. This study also supports the fact that medicines for symptom relief, such as high doses of morphine and other opioids, do not hasten death. So in fact, hospice care, palliative care, does not hasten. The Institute of Medicine made a number of recommendations for improving palliative care. They suggest the need for better measures of quality of care and palliative care outcomes, better tools and strategies for improving quality of care and holding systems responsible for palliative care quality, the revision of mechanisms of financing palliative care, the reform of drug prescription laws and regulations which impede pain control primarily through their interference with the availability of opioid drugs, the need for palliative care to become a subspecialty, which has happened now in the United States, education at undergraduate and graduate levels of medicine, and public education initiatives. The Institute of Medicine further recommended these recommendations for improving palliative care, specifically in cancer. They suggest that centers of excellence in palliative care should be established within cancer centers. Research in palliative care should be required for NCI designation of Comprehensive Cancer Center. The main healthcare financing agency needs to investigate models of service delivery and financing of palliative care. Private insurers must provide coverage for palliative care. Patient education programs in cancer must include information on palliative care. National Cancer Center Network practice guidelines should be developed in palliative care, and these have occurred. An increase in research and funding in palliative care. This is a need not only in the United States but in other countries. At this point in this online curriculum, we're going to focus on the role of the psycho-oncologist in palliative care. There are a number of roles for the psycho-oncologist in palliative care. One of them is in helping the provision of pain and symptom control. Psycho-oncologists can provide pharmacologic as well as non-pharmacologic adjunctive therapies for a variety of physical symptoms, including pain, nausea, vomiting, fatigue, and insomnia. This can be provided through a number of pharmacologic interventions using psychotropic drugs that often have their primary indication for depression, anxiety, even psychosis, but are useful as adjuncts for analgesia, nausea, vomiting, fatigue, and sleep. The psycho-oncologist needs to be familiar with the management and assessment and diagnosis of major psychiatric symptoms and syndromes that occur in patients with advanced cancer. Patients with advanced cancer are particularly vulnerable to psychiatric disorders and complications. There are a variety of prevalent psychiatric symptoms that occur that make up the symptom burden of patients with cancer. Worrying, nervousness, lack of energy, insomnia, sadness are amongst the most prevalent symptoms reported by patients with advanced cancer. And there are a variety of neuropsychiatric symptoms and syndromes that occur in patients with advanced cancer, including anxiety disorders, depression, cognitive impairment disorders such as delirium, and issues related to depression and delirium such as suicidal ideation, desire for death, demoralization. Psycho-Oncologist plays an important role in providing psychotherapeutic and behavioral interventions. There are a variety of basic psychotherapy interventions that have been developed in physically healthy populations that can be applied towards treating symptoms and distress in patients with advanced cancer. These include individual and group supportive therapies, cognitive behavioral interventions, interpersonal psychotherapy interventions. In addition to those basic types of interventions, a variety of novel psychotherapy interventions have been developed and are now being tested in various stages of clinical trials that have been designed specifically towards improving quality of life and psychological distress and psychological symptoms in patients with advanced cancer who are in terminal phases of illness. Some of these novel interventions include life narrative and life review interventions. Related interventions include dignity-conserving therapy and other generativity and legacy-related interventions, life completion interviewing, cognitive existential interventions, primarily studied in group formats, meaning-centered psychotherapy developed in both group and individual formats, and then a variety of bereavement interventions, including family-focused grief therapy and other models of bereavement counseling. What are the legitimate goals of psychotherapy in palliative care? The basic approach is to provide support and presence. And of course, presence and non-abandonment is a basic element in psychotherapy in the terminally ill. By presence and non-abandonment, one provides a constant source of presence. One escorts the patient through the course of treatment and the dying process. Support, providing support allying with defenses, including the occasional support of denial of the proximity of death. One of the more interesting questions in terms of the goals of psychotherapy in palliative care is whether we can accomplish something more ambitious in psychotherapy with patients who are terminally ill. Whether a legitimate goal of psychotherapy in palliative care includes acceptance of the life that one's lived, helping patients achieve a sense of life completion, meaning, coherence, helping establish a firm sense of legacy, and even striving towards some type of acceptance of death with a sense of peace and equanimity. At the basis of psychotherapy and palliative care is also the concept of compassion through several practices of compassion, through hospitality, presence, and listening. By hospitality, we mean that creating the setting for community and communication, recognizing that we share a human condition and that we are connected, that the therapist-patient relationship is less hierarchical and more of what Martin Buber would term the I-thou relationship. By presence, we mean to give the other or the patient our full attention. We are in fact often referred to as the attending physician, to be fully present for the other, transcending our own concerns. And then finally, listening, to hear and to respond to patients in a way that makes the patient know that they have been fully understood. This at its core is the essence of empathy. So empathy and compassion are essential ingredients to psychotherapy and palliative care. Some of the other roles for the psycho-oncologist include addressing spiritual and existential issues. There are a number of definitions of spirituality. At its most basic, spirituality is that which allows a person to experience some transcendent meaning in life. But there are other sufficient definitions of spirituality, certainly. Our role as psycho-oncologists is also to overcome barriers to effective communication with patients about spirituality. There's often a discrepancy between physicians and patients as it relates to their willingness or interest or their opinion as to the appropriateness of discussing spiritual issues, particularly when there's a mismatch between the spiritual beliefs of a patient and the physician. There's often lack of time on the part of physicians to discuss these issues and lack of training. And there's also a feeling amongst healthcare providers that these discussions may be inappropriate or intrusive and outside of their area of expertise. What's clear, however, is that a significant number of patients and their family members who provide care for them actually want to discuss spiritual issues with physicians. And that's illustrated by this survey published in a paper by Karen Steinhaus. This is another slide that shows that patients really want to talk about not only spiritual issues but the meaning of death with their healthcare providers, not merely chaplains and other spiritual leaders, but with their physicians, who they see as escorting them or engaged with them in a struggle of life. Irvin Yalom described 4 basic human existential concerns: death, freedom, isolation, and meaninglessness. Death involves the inevitability of death and the limitations of life. Freedom involves the fact that we have the freedom to make our lives as we will, and that we have a need to respond to the fact that we're alive, that we need to exert our will in a world that is essentially without structure and that we create, that's groundless. Isolation refers to our ultimate aloneness, that we're born alone and we die alone. And meaninglessness, or the absence of obvious meaning to life, involves the drive that Viktor Frankl would say is a basic human instinct to find meaning, to search for meaning in an uncertain world, a world without obvious external. David Kutzane described the role of the psycho-oncologist in addressing some of these spiritual and existential issues, where he described some of these concerns: death, loss, isolation, meaningless, and described some of the forms of distress that are manifest in patients related to these existential concerns: death anxiety, grief, loneliness, demoralization, with the concomitant symptoms that can occur related to some of these basic existential concerns, and some suggested approaches in terms of psychotherapeutic approaches. Interpersonal psychotherapy, supportive grief therapy for isolation, supportive psychotherapy, grief therapy for loss, CBT and other existential psychotherapies for death anxiety, narrative and dignity-conserving therapies, existential therapies, meaning-centered psychotherapy for meaninglessness and demoralization, for instance. An additional role of the psycho-oncologist is to facilitate effective communication with family and medical staff. It's often the role of the psycho-oncologist to help facilitate end-of-life discussions and decision-making amongst patients, families, and palliative care teams. The psycho-oncologist often serves as an advocate for the patient as questions arise, assists in conflict resolution between patient, family, and staff. The important elements of communication in palliative care include basic listening skills, skills around breaking bad news, and therapeutics. Another role of the psycho-oncologist is to help deliver culturally sensitive palliative care. Awareness that cultural factors influence a patient and family's attitude towards death and dying. Attempts to incorporate patients' cultural and religious beliefs into evaluation and intervention processes to provide proper physical and emotional relief are essential. And cultural and religious values surrounding patient, family, and physician roles in decision-making, pain and symptom management, grief and bereavement are also important issues. The psycho-oncologist is also important in providing support through the bereavement process, providing continued support to family and caregiver, recognizing emotional, cognitive, physical, and behavioral features of grief, to be aware of psychiatric complications of grief, such as depression and anxiety disorders, and to consider interventions for grief and bereavement, including a variety of interventions such as family-focused grief therapy, interpersonal and cognitive behavioral models of grief therapy. The psycho-oncologist is also often the member of the team who is sensitive to the fact that the palliative care team itself experiences grief and bereavement through the losses that they experience when patients that they care for. At this point, I'd like to talk a little bit about the dying experience and what can be achieved beyond a basically good death. Symptom management is rightly the first priority in palliative care, but it must not be allowed to become the ultimate goal of palliative care, or the only goal. The challenge for palliative care clinicians and the psycho-oncologists who are consultants or part of the palliative care team is to provide symptom management while not being blind to the profoundly personal nature. Most of the literature can agree on what some of the basic elements are of a basically good or a basically bad death. A bad death is characterized by needless suffering, disregard for a patient or family's wishes or values, offense of a participant's norms of decency, neglect, violence, or unwanted and senseless medical. A basically good death is characterized as a death that's free from avoidable distress and suffering for patient, family, and caregivers, a death that's in accord with patients' and families' wishes, and a death that's reasonably consistent with clinical, cultural, and ethical standards. The Institute of Medicine suggested that there are a number of domains of quality end-of-life care from the professional perspective, that one needs to provide overall quality of life during the dying process, focus on physical well-being and functioning, psychosocial well-being and functioning, spiritual well-being, care to pay attention to the patient's perception of care, and the family's well-being and perception of care. From the patient's perspective, receiving adequate pain and symptom management is important. Avoiding inappropriate prolongation of dying and achieving some sense of control is important. Relieving burden and strengthening relations with loved ones is important when one approaches death from a patient's perspective. The question is whether there is some type of more expansive vision of a good death beyond a basically good death. This more expansive vision of a good death is intended to encourage a sensitive regard for dying patients and a more positive view of how life can be lived in the face of death. Such a vision sometimes carries potential risks because of the expectations that patients need to achieve certain specific goals within the dying process, and they need to go through dying process in specific steps, etc. Part of the elements of perhaps a more expansive vision of a good death, a better death perhaps, is a death that comes with reasonable warning, a death that occurs in the company of loved ones, and a death that provides the opportunity for people to reconcile with family and friends and achieve meaning, peace, and a transcendence. A number of tasks for clinicians in the care of the dying have been described. They suggest that one of the tasks for clinicians in the care of dying is to ask themselves, how do I understand what this patient is experiencing? How do I tolerate my own sense of helplessness? The importance of one's presence, non-abandonment, and this notion of a mission of accompaniment, respect and reverence for the sufferer, transmitting a message of admiration to the patients, suggesting to the patient that they won't be forgotten and that we as clinicians have benefited from having met them, and remembering that the patient is the teacher, and each patient that we care for that goes through the dying process is a teacher. Tasks for patients at the end of life have been described as well. And this notion that the dying process can be a period of growth and development as well. Ira Byock described some of these tasks for patients at the end of life. One is to achieve some sense of completion with worldly affairs. Another is to achieve a sense of completion in relationships with community, family, and friends. To achieve some sense of meaning about the life that one has lived. To experience love of self and others. To accept the finality of life and one's existence as an individual and surrender to the unknown, or letting go. Many of these tasks are achievable and many are not achievable by individual patients. The question remains as to whether we as psycho-oncologists have the ability, the skills, or the tools to help patients, as many as patients as possible, achieve some of these. A more existentially informed list of end-of-life goals might include the following. Developing a sense of life completion. And I'll talk more about what life completion consists of. Achieving some sort of sense of coherent meaning about one's life. Leaving a legacy. Facing death with peace and equanimity. And then finally, two related factors, the acceptance of death and the acceptance of the life that one lived. Talk a little bit more about completion. This is a table of patients' consensus attributes of what a good death is, and they include a number of components of life completion. Patients wanted to be free of pain. They wanted to be free of shortness of breath. They wanted to be kept clean. They wanted to name someone to make decisions. They wanted treatment preferences in writing. They wanted to know what to expect about their physical condition. They wanted to feel that their family was prepared for their death. They wanted to have a doctor who knew them as a person, and they wanted to have a doctor with whom they could discuss their personal fears. And these are some of the elements of attributes of a good death that relate to the process of life completion. Being able to say goodbye to important people, to resolve unfinished business with family or friends, to share time with friends and family, and to remember personal accomplishments. These are some of the attributes of life completion: a life review, resolving conflicts, asking for forgiveness, giving forgiveness to those who've who've asked for it, or maybe have not asked for it. Spending time with family and friends, saying goodbye, giving to others with time, special things or wisdom, things that one's learned in one's life, leaving some sense of legacy, expressions of faith and meaning, and coming to some sense of peace about one's life. Ira Byock talked about the important tasks of relationship completion. He wrote that there were 4 tasks of relationship completion: expressions of regret, expressions of forgiveness, acceptance of gratitude and appreciation, and then finally leave-taking or saying goodbye. This breaks down into 4 things or 5 things that people need to say before they die. 1 is, I forgive you. 2 is, please forgive me. 3 is, I love you. 4, thank you for loving me, and goodbye. In addition to sense of life completion and a sense of coherent meaning about one's life and legacy, the notion of facing death with peace and equanimity through acceptance of death or acceptance of life lived is another potential goal of end-of-life care, or goal for task for patients who are dying. And the question remains as to whether psycho-oncologists in their psychotherapeutic work with patients who are dying can help patients achieve such goals. Empirical evidence suggests that cognitive and emotional acceptance of death leads to more desirable outcomes in terminal. Kubler-Ross, in her Stages of Death, described the last stage of death as acceptance of death, and what she meant by that was acceptance means coming to terms with the situation without feelings of hostility, allows time for facing the reality of death in a constructive way. Clearly, the acceptance of death is a very complex and dynamic construct. It involves a number of cognitive, emotional, and behavioral components. The behavioral components include both speech and actions. Patients may talk about hope and living to see events that are unreasonably far away in terms of the reality of the prognosis, but their actions may in fact announce that they have a full understanding of the limitations of their prognosis, etc. The cognitive awareness of one's poor prognosis is also quite complex. It may involve awareness of the proximity of death, acknowledgement, insight, and finally acceptance. And then there's this emotional component of acceptance of death. Ray and Prigerson and colleagues described a form of acceptance of death which they called peaceful awareness of a terminal prognosis. It involved both cognitive and emotional acceptance of death. This cognitive acceptance in death involved an intellectual awareness of one's terminal prognosis. The emotional acceptance involved peace and equanimity, or the absence of hostility in face of death. In some of their more recent work published in 2006, patients who had an acceptance of death or a peaceful awareness of death, both a cognitive and emotionally peaceful awareness of death, had higher rates of advanced care planning, had better quality of death, and had more positive physical and mental health outcomes in bereaved family members. A study done several years ago by Chochnov and colleagues looked at the relationship between insight into the terminal prognosis of one's illness or cancer and levels of depressive symptoms. Chochnov asked patients what they understood about their illness and how serious they believed things were, and rated patients on a scale of 0 to 3 as to the degree of insight that they had into the terminal nature of their illness. Patients who scored a 0 or had no information. One, they had no insight. They believed their illness was curable, but not terminal. Two, they had some limited insight. And three, they had full understanding of the gravity of the illness and the imminent. What Chachnov and this group found was that patients who had partial or complete insight into the terminal nature of their disease, cancer, had significantly lower levels of depressive symptoms than patients who had no insight or did not cognitively accept their terminal prognosis. Another piece of evidence suggesting that acceptance of death, at least on a cognitive level, may have better mental health outcomes as well. So if we know that that acceptance of death on both a cognitive and emotional level leads to better health outcomes, better quality of dying, less distress during the dying phases of illness, should this not particularly be a goal of psychotherapeutic care in patients who will? This leads to the question of whether we, as psycho-oncologists, might have more ambitious goals in our psychotherapeutic interventions with patients who are terminally ill. The notion that acceptance of a life lived or acceptance of death may be a fruitful area to explore gently as patients allow, rather than forcing them to deal with some of these specific issues. Facing death and facing the fact that time is finite can be the impetus for transformation. It forces one to turn around and face the life that one has lived. This can enhance the process of pursuing a sense of coherence, meaning, and completion of one's life. It allows for the realization that the last chapter of one's life is the last opportunity to live to one's full potential, to leave behind an authentic legacy, to connect with the beyond, and to transcend life as we know it. The goal is to preserve the idea that there is still life to be lived, still time to become, so that one can die with a sense of peace, equanimity, and acceptance of the life one's lived. Through the acceptance of death, one can live life more fully and complete the tasks of living and dying and preserve. In summary, a cultural shift in contemporary society's orientation toward just dying must take place. The shift is from seeing dying only as a time of unavoidable suffering to understanding dying as a normal and valuable part of a full and healthy life, a time of opportunity for growth, enhanced meaning, and sense of completion. In conclusion, psycho-oncology clinicians, by helping move the goals of palliative care beyond symptom management and addressing the human, spiritual aspects of care, are in a unique position to contribute to a healthy reincorporation of the value of dying within the mystery of life. This is a list of references that the reader might find helpful in further pursuing information about palliative care, psychiatry, and psycho-oncology.
You have just completed a lecture from the IPOS online curriculum, which has been generously supported by the European School of Oncology. If you have further interest in joining IPOS or in learning more about the European School of Oncology, please contact the organizations directly. At this time, we hope you will complete the course evaluation. The web link and password for the evaluation are provided on the following slide, as well as on the web page next to the title of this lecture. We hope you have found this lecture to be useful and informative, and that you will continue to take all the lectures as they become available.